All right, everybody, we're going to do Chapter 15, Feeding and Swallowing Disorders. Let's break this up into two parts. This is going to be part one. All right, dysphagia. Dysphagia is a swallowing disorder. An individual will exhibit an unsafe or inefficient swallowing pattern that undermines the eating, drinking process. And this can occur at any time, but these are most common among infants and the elderly. We're going to do a couple vocabulary terms here. Number one is deglutition, which is the complex neuromuscular act of moving substances from the oral cavity to the esophagus. So this is really just a fancy name for swallowing. The substance that's being moved is called the bolus. So we're going to take food and put it in our mouth. We're going to chew it up, and we're going to turn it into a ball or a bolus that we're going to then move from the front of our mouth to the back of our mouth, and then we're going to swallow it down. Some more terms. Penetration is when food or liquid enters the larynx, which can cause choking and respiratory distress, right? So you start to get food down into your airway, and that's when you're going to choke. You're going to get that feeling when you've got to move that food back up. You might cough, you might do something to get that food back up into your mouth and then back down the right way. Aspiration is when the food or liquid passes through the larynx and into the lungs, which can cause asphyxiation, right? So stoppage of breathing, or a pulmonary infection such as pneumonia. And what's hard is when food gets down into the lungs, there's very little we can do about it. So, it's going to cause that infection, and that can be really serious for some people. So we've got swallowing stages or phases that we're going to need to talk about. The oral preparatory phase, the oral phase, the pharyngeal phase, and the esophageal phase. So let's talk about each of these. All right, the oral prep phase. This is to prepare the substance to be swallowed for swallowing. It begins when the food or liquid enters the mouth, and it contains the material in the oral cavity by closing the lips, manipulating and preparing the food or liquid into a cohesive ball or bolus, right? So this phase starts as soon as the food or liquid enters the mouth, and we're going to start turning that food or liquid into a bolus and prepare it to be swallowed. The oral phase, we're going to move the bolus to the rear of the oral cavity and prepare it for propulsion down the throat. So the oral phase begins as the tongue propels the bolus to the back of the mouth. So in the oral prep phase, I've made the bolus. The oral phase, as soon as I'm going to start to move the bolus to the back of the mouth, that's when the oral phase really begins. The pharyngeal phase, to propel the bolus downward through the throat into the entrance of the esophagus. At the start of this phase, the pharyngeal swallow reflex is triggered. So as soon as you begin to swallow, the pharyngeal phase has started. The posterior pharyngeal wall, so the back of your throat, and the back of the tongue create pressure that moves the bolus downward through the throat. The esophageal phase moves the bolus through the esophagus into the stomach. The bolus passes through the upper esophageal sphincter. It's propelled through the esophagus by an involuntary wave or contraction. So we make these just natural contractions that just very naturally and hopefully easily moves the food through the esophagus. It then passes through the lower esophageal sphincter and into the stomach, and that's the completion of the swallowing the phases. This can range, these 4 phases can range from about 8 to 20 seconds for adults, the esophageal phase. The esophageal movement is going to slow as we age. So it's referred to as a decrease in esophageal motility. Those waves are going to take longer and longer, those contractions. They're going to start to slow down, and the timing's thrown off a little bit and makes it a little bit more difficult as we get older. All right, so the disordered swallow is dysphagia. Dysphagia occurs when an individual exhibits difficulty in at least one of the phases of the swallow, causing swallowing to be inefficient or unsafe. And it's important to remember that dysphagia is a symptom and not a disease. So dysphagia is caused by a stroke. It can be caused by ALS, Lou Gehrig's disease. It can be caused by MS. A lot of things can cause dysphagia. So dysphagia is a symptom of something else. When swallowing is inefficient, it does not provide adequate nutrition. And when swallowing is unsafe, individuals are at risk of penetration or aspiration because of poor coordination or management of the bolus as it moves through the swallowing phases. So it can be inefficient, which is a problem, or it can be unsafe, which is a serious problem. All right, so let's talk about pediatric feeding disorders specifically. A feeding disorder is when a child's persistent failure to eat adequately for a period of at least 1 month, which results in a significant loss of weight or a failure to gain weight. The child also displays one or more of these: unsafe or inefficient swallowing, growth delay affecting height and or weight, lack of tolerance of food textures and tastes, and or poor appetite regulation. What are the characteristics of pediatric feeding and swallowing disorders? They can be unsafe, inadequate, or inappropriate. So let's talk about these. Unsafe feeding and swallowing typically results from the dysfunction of or damage to a child's oral motor system or an inappropriate eating rate, either too fast or too slow, right? So like we talked about when we talked about the phases, right? Things have to happen in a certain amount of time, and if feeding takes too long, it can throw off the timing of the swallow, and that could be a problem. Or if it goes too quickly, it can also throw off the timing of the swallow. Swallowing dysfunction can affect planning, timing, coordination, organization, and sensation. Dysphagia frequently accompanies a number of syndromes, particularly those that feature low muscle tone, hypertonia, delayed motor development, and physical deformities affecting the oral motor area. Children with Down syndrome may exhibit hypotonia, contributing to a weak suck, which can result in a swallowing impairment. Children with cerebral palsy also present a significant risk factor for dysphagia, right? So if children have a hard time sucking either on the nipple or the bottle, right, they're going to have a really hard time getting food into their mouth, and then once it's in their mouth, the timing is off. They can get tired. We'll talk about these things. They can make things really difficult. So more causes and risk factors: children with low birth weight are more likely to have dysphagia, children with developmental disabilities, children who are premature, children with prenatal drug exposure, and children who have diet restrictions. All of these kids are going to be at risk for dysphagia. Now let's talk about inadequate feeding and swallowing. It can swallowing can be inefficient. So like we said, it can either take too long or it can be too fast. So if it takes too long, everybody gets frustrated. Food might be in the child's mouth for a long time. And we have a high risk of dysphagia occurring and either food going into the airway or into the lungs. Over selectivity, so children may only be able to tolerate a certain type of food, a certain consistency of food, one food in particular. Children who may be on the autism spectrum might only have one kind of food they like, and they're not getting a complete diet by doing that. It can also be refusal. So if children just either aren't able to tolerate food, if they're choking a lot, they might just stop eating altogether. If they really dislike the textures of the food, they might stop eating. So there can be a lot of reasons why children might refuse to eat. And then a feeding delay. So if children are having a hard time going from breastfeeding, going to the bottle, going to using fingers to pick up food, and going to, hard or, moving from liquids to solids, if they have a delay in any of these areas, they can stop getting the nutrition that they need along the way. All right, inappropriate feeding and swallowing. Children who exhibit inappropriate feeding behaviors demonstrate undesirable and disruptive behaviors during meal times. If the inappropriate behaviors are significant, the children's growth and development may be compromised as successful feeding is disrupted, turning mealtime interactions into serious and stressful struggles between caregivers and children. Inappropriate feeding behaviors include screaming, spitting, throwing, hitting, and other similar actions, right? So mealtime's supposed to be this really pleasant time. And if all of a sudden mealtime's taking a long time, the child is uncomfortable, the food doesn't feel right to the child, all of a sudden they don't like it, and all these negative behaviors happen, then the parents become upset and worried and concerned, and it can really spiral into a really negative time, which is supposed to be, a happy, easy time of day. More causes and risk factors, being overactive and overstimulating. So if kids are moving around during mealtime, if there are brothers and sisters running around, if the television's on, if a lot of things are happening, right, that can lead to problems feeding and swallowing. If we have a child who's underactive, passive, and unengaged, so a child's not interested in food, doesn't really care if they eat, doesn't like to eat, that's a problem. If parents are rigid, directive, and demanding that you have to eat this one food for whatever reason, child doesn't want to eat that one food, that can be a big problem. Sort of related to the first one, being chaotic, disorganized, and frenzied. If parents are all over the place, talking on the phone and trying to feed the child and things are crazy. And then also if parents are overly concerned, anxious, and fearful, which would kind of be a natural reaction, I think, if your child's having a hard time eating, they're not growing, they're choking when they're eating, that can be really scary. So again, things can kind of cycle and get out of control fairly quickly with children who have feeding disorders. All right, early identification and referral. The timely identification of pediatric feeding and swallowing disorders is critical so that immediate intervention can sustain the child's health and nutrition. Typically, newborns stay in the hospital for only 2 or 3 days, but longer when complications are evident or when the child is underweight or premature. So if the child's having a hard time feeding in the hospital, they're not going to get sent home. They're going to work with nurses with the speech language pathologists to try to get them eating and comfortable before they're sent home from the hospital. The SLP will conduct a comprehensive assessment that includes a case history, a physical feeding, swallowing evaluation, and observation of mealtime interactions. So let's talk about those things. A case history. Information on the child's and family's eating and feeding experiences to explore possible problems, to study changes in behaviors over time, and to document specific manifestations of the disorder. Of particular importance is the child's feeding history, a parental report on the length of meals, the quality of intake, and the child's progression from breast bottle to purees and solids helps the specialist identify where any breakdowns might have occurred. A history of formulas used and volumes tolerated gives helpful information regarding potential referral to other professionals, such as an allergist or an endocrinologist. Right? An endocrinologist will be a doctor who specializes in hormonal differences or imbalances. So that can be things like diabetes, thyroid problems, things like that. Right? So we really want to know how much the child is eating, what they're eating, and what their history has been over time. We'll also do a physical feeding and swallowing evaluation, so a careful evaluation of the structures and functions of the child's oral motor mechanism, observation of the lips, tongue, jaw, teeth, and hard and soft palates. A structural exam studies the physical nature of these structures. The functional exam assesses how they work together during eating and swallowing. And it examines the structures and functions at rest when not being used for feeding and swallowing, right? So we need to look at both the child's anatomy and physiology when they're eating and when they're not eating. So what are they able to do with their lips, with their tongue, with their jaw, with their teeth, with their hard and soft palates? We want to see all this in real time, both when eating and not eating. Our goal is to ensure that nutritional needs are met for healthy growth and development, and that feeding and swallowing do not endanger a child's life. This can mean providing alternative or supplemental nutrition via tube feeding, at least for a while until we're able to go back to oral feeding. Once those immediate goals are achieved, focuses on improving a child's own ability to meet her nutritional needs and to see eating as a psychologically pleasant experience rather than a negative experience. Children who are unable to meet their own nutritional needs orally and whose growth is faltering require an alternative solution. Children who are candidates for supplemental or alternative nutrition are those who cannot meet 80% of their caloric needs orally, who have not gained weight or have continually lost weight for 3 months, whose weight and health ratio is below the 5th percentile, and whose feeding time is greater than 5 to 6 hours a day. So, I mean, imagine taking, we're talking about, if meal times taking 5 to 6 hours a day, how difficult that would be for parents, for the children, be super frustrating and scary. Okay, this is going to end part 1.